And when it comes to medicine, I think that the stakes are even higher because medicine is a matter of life and death.
Hello, everyone. Welcome to Phi-Sci. This is a YouTube channel based around conversations about philosophy and science. This is my first interview, so I hope it all goes well. Joining me today is Adrian Erasmus, soon to be Dr. Erasmus. Adrian is finishing his PhD in the Department of History and Philosophy of Science in Cambridge, here under my supervision, and soon to be Professor Erasmus. Adrian is going on to begin a teaching position at the University of Alabama. Adrian, thanks for speaking with me today.
Thanks very much for having me, Jacob.
You are a philosopher of science and medicine. What is philosophy of medicine?
Well, I think a lot of people would probably have slightly different answers to this question, but my view is that philosophy of medicine is the pursuit of answers about conceptual and methodological questions about medical practice, questions about how we should infer conclusions about disease, about interventions in medicine, from evidence that we gather in medicine, and how the concepts that we use to make these inferences influence how we make those inferences.
Can you give me a couple of examples? What are some of the concepts that are important to philosophy of medicine?
So one pretty obvious concept is the concept of disease, and how we think about what a disease is and whether it is something that is defined by sort of naturalistic inclinations. So whether a disease is something biological at base, and how we decide whether someone is diseased is based on whether they are there's some sort of deviation from the norm in their biological function. Another way to think about disease is whether it has some normative features. So whether, as a society, the values that we have influence whether we consider some sort of condition that someone has is a disease or not. Another related concept is health and how it relates to disease. I'm specifically interested in the concept of effectiveness of medical interventions. So how do we think about what counts as an effective medical intervention, and how do we decide what effectiveness is?
Okay, so these are philosophical questions about medicine. Why does medicine need a philosophy? And can't doctors just go about doing their work just fine without philosophical discussion about these concepts and methods?
Well, I think I could answer that a little bit broader at first and then get down to the specifics of medicine. So I think that generally science, any science can benefit from philosophical investigation. So how scientists go about their scientific investigations and stuff like that has benefited a lot from philosophy. So whether what scientists talk about on an unobservable level, whether those things are real or not, has some influence on how scientists speak about their conclusions, and that may influence the way in which we develop trust in those conclusions. And when it comes to medicine, I think that the stakes are even higher because medicine is a matter of life and death, and it also influences our everyday lives. So we're constantly exposed to medical practice. You feel a little bit ill and you go on the internet and you try and find out what you've got before even going to a doctor. And so I think that the way that physicians and medical researchers think about the concepts that they use will have some influence on how they first communicate what's happening to a patient at the patient level, but also influences how they make the conclusions they do. Now, I think it's true to say that doctors can probably practice medicine without philosophical investigation, but I think that a lot of disagreements that occur in medical practice are probably a result of conceptual disagreement. It's a misunderstanding of what a disease is, for instance, that might lead to one person saying that some controversial disease is a disease or not. And when that happens, often doctors can be somewhat dogmatic in their interpretations of these concepts. And philosophers are trained to unpack these things and help people who may have conceptual disagreements see where exactly they disagree with one another.
Let me ask you to give a specific example of this. So can you tell us an example in which there's some debate about a particular disease and maybe some doctors are being dogmatic and philosophers can come along and help unpack, as you say?
A paradigm example is homosexuality. So in the past, homosexuality was considered a disease. And it was considered a disease because it seems to be deviation from normal functioning, right? So along these lines, most people are not homosexual. Therefore, there might be some biological reason for this, that people are homosexual. And if we take that approach and we see homosexuality as a deviation from the norm, then from normal functioning at least, then it might be considered a disease. Now, obviously, that has serious implications for society. We shouldn't be thinking of homosexuality as a disease. So when we bring in normative considerations into the concept of disease, we can see that we might conclude that homosexuality is indeed not a disease. So the values of society might say that, well, there's nothing wrong, there's nothing harmful for human beings who are homosexual. And once we see disease in that way, we might be able to get past disagreements about whether it is a disease or not. Once we bring in these normative considerations, those who might be on the fence about thinking homosexuality as a disease based on biological reasoning could be brought to believe that it's indeed not a disease. Another one might be something like ADHD. So ADHD is often thought of as a disease. But if you look across the world, there's places where ADHD is not considered a disease in the same way that it is in many other places. So, for example, in France, ADHD is not diagnosed as much as in places like the USA or the UK. And there might be conceptual disagreements across these two domains where ADHD features, and philosophers can unpack those concepts and help people come to some sort of consensus about that sort of thing.
Okay, and that is a nice segue into speaking about your dissertation, because the first chapter of your dissertation is about nosology, or disease classification. Can you tell us the broad contours of what nosology is? What are the various options for disease classification systems?
Yeah, so nosology is this domain of medicine, of medical research, that's concerned with classifying diseases. And its main aim, generally speaking, is to improve communication between researchers and physicians and health insurers and so on. But disease classification and nosological systems, as they might be referred to, also contribute to other goals in many other areas of medicine. So one specific area where it's important is therapeutic prediction. The one issue facing nosology is that there are several ways in which we might classify diseases. So once we consider something a disease, we might want to put it into categories. We want to categorize those diseases. And we might choose one of several ways to do this. So we might categorize diseases according to their causes, according to their etiology, that is. So what are the causes of disease? For example, the Mycobacterium tuberculosis is the cause of tuberculosis. So we might say that tuberculosis is the disease that is caused by uh, uh, Mycobacterium tuberculosis. Another way that we might classify diseases is according to their symptoms. So this is common in psychological, in psychiatry, in psychiatric practice. Things like the DSM-5, the nosological system that they use, classifies diseases according to the clinical picture or the syndrome that manifests or that is observable. So we might think of depression as a set of symptoms that a person exhibits, something like suicidal thoughts, the sort of neglect, feelings of anxiousness, and so on. But we can also think of physical diseases in this way. So tuberculosis, going back to tuberculosis, is the disease that exhibits, coughing, difficulty in breathing, and so on. So we might classify physical diseases according to the symptoms as well. And finally, there's another way to classify diseases by their underlying pathophysiology, and this looks at sort of the mechanisms underlying a certain disease within one's body. So tuberculosis affects the lungs, and we might look at the mechanisms of how Mycobacterium tuberculosis infects one's respiratory system, and we might classify tuberculosis in that way. So there's three general ways that we might think of this. First is the etiological approach to disease classification. Then you have the symptom-based approach and a pathophysiological approach.
And so you said that all of these approaches are being used in different domains of medicine. Is there a better one and a worse one, or should we just be pluralist about these nosological systems? Just they're all fine.
Well, I think that we should be pragmatic about it. I think that pluralism is probably the right way to go. I don't think that there's a problem with having all of this information about diseases. We definitely need all that. And we should be pluralist about how we classify diseases. But I do think that when looking at our disease classifications and picking one out, the goal that we're trying to achieve, the specific goal that we're trying to achieve in medical practice at that time, should dictate which classification system we use. So because I'm concerned with medical effectiveness and the prediction of how an intervention will help an individual or a population, I think that one good approach for that is to use the pathophysiological system of disease classification, just because it has underlying mechanistic information that would be helpful in making better inferences about medical effectiveness.
Okay, I want to pick up on this idea. So having mechanistic evidence helps to make reliable predictions. The nice thing about your dissertation is all of the chapters are tied together around this notion of predictions in medicine. So having knowledge of pathophysiology helps us make predictions because we have mechanistic evidence about the disease. So what's so important about mechanistic evidence? This is the topic of your second chapter.
Yeah, so there's a couple of things that are helpful with mechanistic evidence. So when we're making predictions about medical effectiveness, it's helpful to think about it in a certain way. So when we do medical research, we typically perform RCTs, which is randomized control trials, whereby we gather statistical evidence about the benefit or harms of a specific medical intervention for a given disease. But what we end up with is a bunch of quantitative data about a particular population in an experimental setting. And what we're really interested in medicine and the prediction of medical interventions is how that intervention will help a target population or a target individual. And often what we find is that the statistical evidence And this is not always the case. Of course, statistical evidence can be sufficient to make these predictions. But often what we find is that our predictions based on our controlled settings, our statistical evidence, don't manifest the way that we expect. And often what we'll find is that there are these underlying pathophysiological or mechanistic differences between the sample population that's used in the randomized control trial and the target population that we're aiming to treat. So the view, a common view, is that having mechanistic evidence about the sample population and the target population and comparing that mechanistic evidence will often help us make better predictions about the effectiveness of the intervention in question.
Okay, you called that view a common view. I would have thought that the common view goes under the name of evidence-based medicine. So, what is evidence-based medicine?
So evidence-based medicine is probably the current paradigm of medical research. It's the overarching view that we should be making clinical decisions and predictions about medical effectiveness based on what is considered the best kind of evidence. And proponents of evidence-based medicine claim that the best kind of evidence is statistical evidence in the form of or derived from randomized control trials or obtained through meta-analyses, which is an amalgamation of randomized control trials and statistical data into one sort of mean benefit measure for an intervention. However, I think that perhaps it was wrong of me to say that it's a common view, but it is an increasingly common view. There's a sort of different approach that's been developed called EBM plus, which is evidence-based medicine plus some other stuff. And in this case, that other stuff is the inclusion of mechanistic evidence, because one of the failings, or one of the what often happens with the evidence-based medicine approach is that we fail in our predictions, even if we use the best evidence that we have. And EBM Plus proposes that the way that we can get past this is to include mechanistic evidence, which typically proponents of evidence-based medicine consider to be at the bottom of our hierarchy for what is considered the best evidence. So there's these two sort of clashing views. And I think that the EBM plus approach is probably becoming a bit more common than most people probably thinks.
Okay. So is the EBM plus movement then denying the evidence-based medicine claim that randomized control trials are our best form of evidence? Isn't it true that randomized control trials are the best kind of evidence that we can have to test a new drug, say?
Yes, I mean, I don't think that, I think it would be wrong to say that the EBM plus movement is saying that randomized control trials aren't the best kind of evidence. I think that the view is something more like we should be using both kinds of evidence. We should have the randomized controlled trial evidence and meta-analytic studies, but include mechanistic evidence because this will help us make better predictions. The sort of prevailing view among the proponents of EBM plus, as far as I can see, is that the mechanistic evidence is augmentive. It helps us. It's not something to disregard, specifically because it can give us information about whether an intervention may indeed harm individuals in the target population when we think it might actually be a benefit. So I don't think that they're denying the sort of place of randomized control trials on our evidence hierarchies, but they're just saying that mechanistic evidence is important too.
Okay. One of the motivations that you noted a moment ago for considering other kinds of evidence is that our predictions about target populations, when those predictions are based on evidence from randomized trials, those predictions often fail. And one of the reasons you cited was that there are differences in our target patients, our population, patients in clinic, compared to subjects who are in a trial. Are there any other reasons why predictions based on randomized trials might fail, might be unreliable?
I think that there definitely are. I think that a major reason why randomized controlled trial evidence might fail to be transported to a target population is because of pervasive bias in medical research. So there are a number of biases that may influence our inferences within the trial context, but also there are biases across medical research that have some implications for how we make inferences about target populations. And I speak about a particular kind of bias, which I call metabiases. So a typical bias, which we might call a methodological bias, is something like confounding or confirmation bias, whereby a medical researcher might unconsciously look for data that confirms their hypotheses, and this can happen within the trial itself. But even if that's not occurring, there are cases where overarching biases that occur in medical practice, these metabiases, can also have an influence on predictions of medical effectiveness. A probably paradigm or exemplar of this sort of bias is publication bias. This is a bias where positive results that are gathered from clinical trials are typically published more commonly or with a higher probability than trials which have negative findings. And there's many forms of publication bias, but we can think of it that way. It's the probability of positive results being published is just higher than those of negative results. And obviously, what this leads to is a sort of skew in our findings, especially when the evidence that we have is amalgamated through meta-analyses. We end up with an overestimation of the efficacy and effectiveness of medical interventions. And when we make predictions based on that evidence, we are perhaps missing a whole body of evidence to the contrary. And thus, we might end up with overestimations of medical effectiveness in target populations just systematically in medicine. And this can lead to issues when we actually are treating individuals in target populations.
Okay, so there are particular forms of bias that affect particular trials, and then there's this notion of metabias that you're referring to, which applies to a domain of medical science. And when both of those are taken together, the idea is that randomized trials, even though they're pretty good methods, the evidence that's generated by randomized trials might be unreliable when we want to make inferences about the effectiveness of an intervention. That's the idea.
Yes.
And what is your proposed solution to that problem?
So I think that there's a number of ways that we can tackle this. And evidence-based medicine has its own approaches. They encourage the use of quality assessment tools for evidence, whereby we not only rank evidence according to whether it's the best kind or not, but whether we think or believe that there's a high risk of bias for that evidence. However, one of the problems with those approaches is, or the quality assessment tools that they propose, is that they tend to somewhat neglect these meta-biases that I speak about. So they actually focus on the methodological aspects, which is a good thing to do, and obviously commendable. We need to assess our risk of bias for these things. But meta-bias is often not accounted for in these tools. So what I propose is the use of a specific method to attenuate our medical predictions or our predictions of effectiveness according to data that we have about these metabiases. So there is a developing research program in medical practice, which is called meta research, which is basically research on research. And one of the goals of this sort of thing is to gather evidence about things like publication bias, the influence of industry sponsorship on studies, and meta research ends up giving us evidence about the influence of these meta biases on our medical research. So what I propose is that we gather that evidence and we formulate an attenuation coefficient, which I call a bias coefficient. And this should help us take whatever we end up deriving as a prediction of medical effectiveness, the effect size that we get, and we use the meta evidence that we have to sort of attenuate that down or lower our confidence in the prediction that we make. And we can do this through the use of a certain bias in the same way that we use friction coefficients for dynamics calculations in physics. We might be able to use meta evidence to derive an empirical bias coefficient to do a similar thing, and thereby lower our confidence in appropriate ways about the predictions that we make in medical science.
So let me try to understand this concretely. Suppose we want to know if some particular drug, like a new antidepressant, is effective at modulating symptoms of depression. So we do a bunch of trials, like the evidence-based medicine people tell us to, and we amalgamate them using a meta-analysis, and we get some measure of how good this drug is. And what you're saying is, when we make a prediction about using this drug in the clinic, we shouldn't infer that the average patient is going to get that much benefit, whatever we measured in the trial. Rather, because we know that the trials that generated that evidence have different forms of bias, and then there's this meta bias that you speak about, we should therefore modulate that measure of the goodness of the drug downwards.
Yes.
How much?
Well, I think that this should be based on the evidence that we have about that specific domain or that specific area of medicine. So let's say that we think that an antidepressant will cure 80% of individuals, or help benefit 80% of individuals that are suffering from depression. But we have meta evidence that tells us that, in fact, there's a number of studies that haven't been published, and industry sponsorship of antidepressant trials leads to an exaggeration of those results by a certain factor. We can perform certain kinds of studies to amalgamate those sorts of evidence to tell us something about how far down we can do that. And we can think of something like a coefficient that we can derive from this that gives us a number between 0 and 1. And that value that we derive, our bias coefficient, can be multiplied by, let's say, the effectiveness that we think we'll have. So let's say it's 80%. Let's say that we have a bias coefficient of something like 0.5, which tells us that, in fact, we should lower our confidence by half in our measure of effectiveness. So when we predict that this antidepressant will work for an individual, we shouldn't be saying that it will have an 80% chance, or for a target population, we should be saying that it has a 40% chance of benefiting those individuals. So that bias coefficient is based on empirical data itself. And I think that this is a good way to help evidence-based medicine and medical practice in general take into account these sort of meta-level biases that occur in medicine.
Okay. Your final chapter is about artificial intelligence in medicine.
Yeah.
Tell us a bit about that. So how is AI being used in medicine, and why Why is a philosopher writing about it?
So yeah, so a lot of AI is being currently implemented in medical practice. So there's evidence to show that medical AI systems can, in fact, be better at making predictions about certain medical inferences than human beings. Take a common example is a breast cancer imaging system, which can predict whether an individual has breast cancer or not based on mammographic information that is fed into the AI system. And results have shown that these systems can be better at predicting whether an individual will have breast cancer or not, better than humans at this. So there's this growing trend in medicine towards AI. AI is used to triage patients, to make inferences like the one I just mentioned about breast cancer, to help us develop drugs, and all of these sorts of things. So I think that there's a huge amount of conceptual issues that come along with AI that philosophers have already been investigating. And a major one of these is, well, if we're relying on medical AI to help us make inferences about individuals, how do we trust those inferences? Especially given that we often cannot explain or interpret what a medical AI is doing when it makes those claims. We cannot explain why the AI system has given us the result it's given us. So when it comes to a breast cancer diagnosis that's derived from a medical AI system, well, how do we know that that is a good inference? Sure, we have that evidence, the quantitative evidence to show that on average, the AI system is better than human beings at diagnosis. But surely, if we wanted to trust that, so one argument goes, we should have access to the sort of decision process of the AI system. And this is one major area where philosophers can help unpack the different conceptual features of or concepts that go into medical AI development.
So, to use a term that came up earlier, the notion of mechanism, are you saying that when we make predictions based on AI, we ought to have better mechanistic understanding of the AI, or just that that's just off the table precisely because of the way AI is designed? We can't get that kind of mechanistic understanding.
Well, often what we find is that it's not necessarily that we want mechanistic understanding. We just want to know, we want to have an explanation, be it mechanistic or some sort of quantitative or law-based explanation about how the AI came to the decision it came to. So it doesn't necessarily have to be a mechanistic understanding of the AI system itself. I mean, we can get that, but I don't think that that's going to tell us much about the actual decision that we obtain, because the underlying mechanisms of an AI system are just that it's a neural network with nodes and values pass along those nodes to other nodes, and then we derive some sort of output. But what we really want to know is, what are the meaning of those values? What's the meaning of those values that get passed through the AI system to result in our output? And this is where the notion of unexplainability comes in, and uninterpretability. So these are notions about, well, human beings are just incapable of understanding and explaining or interpreting how AI systems come to their decisions. We don't know how those values relate to the sort of observable things that we see. And this is a major problem when it comes down to the trust and the confidence in those results, at least on a human level, right? So we can have the quantitative information, but about the reliability, but the patient in the clinic generally doesn't care too much about that. They just want to know, well, why does this AI say I've got breast cancer? Why can't a human tell me that? For some reason, there's this dissonance between trusting the AI and trusting the human doctor. So we want to explain those things. We want to explain how that works.
Okay.
Yeah.
Some people recently have been saying that artificial intelligence is going to revolutionize medicine. Is that true?
Well, I think it already has. I think that these systems have already been put in place. They're in the clinic, and they've led to, in many cases, better decision making, better triage systems, better hospital admissions, and have led to a large benefit for a lot of people. At the same time, we should be careful um, about jumping the gun a little bit. We do want to have some way of evaluating whether the systems that are being put in place or are soon to be put in place will be continually reliable. Um, uh, just as with medical research, as it's happened before, these AI systems are also threatened by bias. So the data that we use to train or develop these AI systems is often itself biased. So although I think that AI has already somewhat revolutionized medicine, there are cases where these systems have led to harms. A common example here is health resource allocation. It's been found that because of the data that the medical AI system was trained on, white patients were allocated resources more often than black patients, and it has to do with understanding how this happened, how the training data, the data we used to develop the AI, influenced or was biased in such a way that this is what happened. And this is one very, very important reason why having a way to explain AI systems and understand them and interpret how they come to their conclusions is important. When things go wrong, they can go wrong in a big way. So we need to be able to understand AI systems, even though we're implementing them.
Thank you. So, Adrian, you've written a really excellent dissertation, and I understand that these will be published as articles in journals of philosophy of science. So I hope that you'll put these articles up on your website so future viewers of this channel can find the articles. After this dissertation, what's next for your research and writing?
Yeah, so I have a number of research projects that I want to develop. The first of these is to continue my research in philosophy of medicine with a view to focusing on the pragmatic aspects of medicine. So it's I've mentioned pragmatics a number of times in the interview, and I mentioned it a lot in my dissertation. But many of these aspects of medicine have pragmatic elements to it. In fact, it's probably true to say that every aspect of medicine has pragmatic elements. So I think that one future project is to unpack these pragmatic elements. So, for example, when it comes to predicting medical effectiveness, what disease classification should we use? That's a pragmatic consideration. When it comes to metabiases, it's a pragmatic issue about what specific domain we're in, what that bias coefficient we might have is, and things like that. And there's so many ways that we can unpack these things, and I think it's important to do so. Another future project that I want to get into is researching more on medical AI, and specifically the intersection of the epistemic concepts such as interpretability, explainability, and these things with value considerations like trustworthiness, and inequity in medical practice. So how do our concepts that we use in our epistemic practice and what methods we use in epistemic practice influence these values that we have and the achievement of those values? We want equitable medicine, but how does the opaque nature of medical AI influence that sort of thing? And then finally, I'm interested in the concept of scientific interpretation more broadly. So because I've researched how the concept of interpretation features in medical AI, it's led me to investigations about how that concept features in other sciences like medicine itself or biology, in physics. How do scientists interpret their explanations, their data, their evidence, and what is scientific interpretation?
Okay, I will be looking forward to reading this work as it comes out in the nearest future. Let's change gears a bit. I want to ask you about your experience in the discipline of philosophy in general. So you come from South Africa. Your early studies were at University of Johannesburg. You did your PhD at University of Cambridge. These are two very different places. What was that like to be a student in South Africa, and how does studying philosophy or being a student in South Africa compare to your experience in the United Kingdom? Are there very striking similarities and differences, or is there anything sort of interesting and noteworthy that would surprise me, say?
Well, I think that the University of Johannesburg helped me develop a love for philosophy. So I've had amazing professors and mentors at the University of Johannesburg, but it doesn't afford the same sort of opportunities to see and interact with really influential philosophers as Cambridge does. So that's one difference that we could probably say is obvious between the two areas. But overall, I think that the philosophical training that you get at the University of Johannesburg is incredibly good, and there's a certain level of diversity that one experiences when they attend the University of Johannesburg that is incredibly beneficial to their philosophical endeavors, right? You have the influence of a vast range of different views coming from different cultural backgrounds and different just experiences of the world. And that's something that at Cambridge you have some of, but not in the same quantity and not of the same quality. So there are benefits to both regions. I mean, at Cambridge, the whole university setup is an entirely different being compared to basically every university in the world. But what the collegiate system at Cambridge offers is, and the Department of History and Philosophy of Science offers, is an interdisciplinary approach that you might not find at many other universities, and which I didn't have at the University of Johannesburg. I think that the jump between the two hasn't been as stark as most would think, but there are aspects that were a bit of a shock. Specifically, this sort of like influence of the interdisciplinary academics in the History and Philosophy of Science department at Cambridge, which has been incredible. Yeah.
Okay, and you are about to move to the United States to take up a professorship there. Tell us about that. Where are you going, and what will the job entail?
So I am starting as assistant professor at the University of Alabama. It's a wonderful job where I get to practice philosophy of medicine. I'm being employed to research philosophy of medicine. So it's within my specific field, and that's lovely. Very excited about this. And I will be working in the philosophy department, but I also will have an affiliation with the McCullough Institute for Pre-Medical Scholarship, or Pre-Medical Scholars. And this is an institute that helps train new pre-med students, or students that are looking to go into medical practice and medical sciences with an interdisciplinary approach to medicine. And that's a very exciting prospect for me. I've worked with medical students before in South Africa, where I taught philosophy of medicine, and I'm very happy that I get to continue working with pre-med students at the University of Alabama, where I'll be teaching them philosophy of medicine and speaking a lot about some sociology of medicine and the history of medicine. And I'm sure that I'll get to do some research in all of these different aspects of medical practice, which is also an exciting prospect.
That is indeed an exciting prospect. Congratulations mightily
Thank you.
on this appointment. Yes. Adrian, thanks very much for this conversation. It's been interesting, and I hope that we can do it again soon.
Yeah, me too. Thank you very much, Jacob.